we have grown not only as a state, but as an organization in this. We're able to now see data in live and real time, and we're able to also create that closed loop system, which allows us to create true data-informed strategies for our neighbors in need. And so what's happened is we're able to target our resources and allocation of resources better than ever before, because we have that live data in a closed loop system. And it looks differently in rural areas versus urban areas versus the coast versus the mountain regions of the state. At an elementary level, of what the technology provided for us was to fill the gaps and needs that we saw in communities better than we were ever done before. Early story of this included rural North Carolina. We were doing a presentation on the platform itself and how you could be a part of that platform. A group of old Army colonels come together and said, hey, we want to help veterans in this population in these 3 counties, but we don't want to recreate the wheel on this. What's the biggest top 3 needs of the community? And what the technology allowed us to do was to show what those 3 needs were, not as an organization, but as a community. And so top 3 needs in that community, one was dental, one was housing, one was transportation. They really targeted on the dental component of that need. And so they raised $50,000, partnered with East Carolina University School of Medicine, and they implemented a dental program called Vet Smiles. That program today has scaled across the entire state of North Carolina and provides dental care to veterans in need that aren't eligible or don't have any other resources at their fingertips for dental needs. Around 1,200 to around 1,200 families a year, veterans a year, are receiving this dental care now because the need was answered by the community. But it had not been for the technology to identify that's where the true need was, they may have implemented a program that would have already been in place, and then we're just duplicating efforts and competing efforts for the same dollars and same funding. So Dr. Mandy Cohen, our CDC director and former Secretary of Health and Human Services, said this best on a panel I was with her on. Collaboration happens at the speed of trust. And that trust has to be shepherded and fostered in a community between organizations, across different agencies, across government agencies. So you have to maintain that. You have to get that trust first. That takes time. And so I say this: do what you say you're going to do, hold each other accountable for that, but have hard conversations in a healthy way that can grow the community and scale what you're trying to accomplish. You have to be mission-minded. You have to think macro level at times, but more importantly, you have to have trust with one another. And that doesn't happen by pointing fingers. It happens by coming to the table with hard conversations of what's not working, but being solution-minded in the same mindset. And so I think patience in that is the biggest thing that I would say to all CBOs as they enter into this work. When you talk about the payment models, right? That's even more important with the payment models, because you're having to reconcile because you're in charge of a little bit more. You're stewards of federal dollars. And so working together as a community of practice to talk to one another offline, to have formal convenings such as the One Continuum, where you can bring people together to have these kind of conversations, is going to be critical to the success of the programs moving forward. Well, I think when you think about access, there's 2 ways you can define access. And the way we do it in North Carolina is people talk about availability and we talk about access. Those are 2 completely wildly different things. You can have access to better healthcare, access to services, but if you have a limited amount of availability to that in the community, that's the gaps that we're trying to fill now, right? I think that when you think about access points, you still have to take the approach of there's a no wrong door. How they get into the delta of care doesn't matter, right? It's that they get into that delta of care. We want you in the technology. We want you in the system so that providers across 28 human service domains, when they land in your system and in your care, you know what's happened to them, that they received legal care here, or they received transportation here, or they received housing benefits here, or they're part of Medicaid over here. One system to be able to navigate a person's journey through the community, that's what we want. How they get there, whether that's through a kiosk, self-service, a provider referral, a phone call, a written down way of referral, there's no wrong door approach. We want to keep that in touch because you got to meet people where they are, right? But we want them in a system that is shared, in a closed loop system that is shared, so that we can better communicate and effectively improve the delivery of services in a community. Historically, pre this model of care, you would have a hospital system have a set of data. You would have a nonprofit have a set of data. You would have the state have a set of data. And all three data sets may be telling a different story of where there are a lack of resources in a community, the lack of availability of services in a community. Well, when you think of big funders, where you're talking about big VA or big HHS or larger healthcare foundations, your data set always holds so much weight based on who you serve and how many you serve. But if you have a community set of data that includes 5,000 unique providers across the state that are putting into this, 50 providers in one zip code that are a part of this continuum of care across all social service domains, that holds weight and holds value because it is a community lens of what the problems or the gaps really are. That's how you can tackle and target resource allocation and funding to better address that need in your zip code versus another zip code, depending on where you live, because it's going to look differently. And being able to do that at a macro level, but also being able to do that at a tactical level, because these dashboards that we use are live. Anybody has access to them at any time. So you're able to make strategic decisions every day of the week, every week of the year, because you have access to that data set that can drive some of those strategies. In North Carolina, we have a large homeless population, much like a lot of other states do. And a lot of those who are experiencing homelessness, unfortunately, are very transient. So they bounce from community to community. They go into different COC to different COC. And even as good as the HMIS system is, it doesn't do the things that this technology does and what NC Care 360 does, what Unite Us does. And so we can better prepare and better see those individuals experiencing homelessness with co-occurring mental health, with co-occurring substance use. When they get to your community, there is a portfolio already laid out and a narrative on this individual, which allows you to step forward and accelerate your ability to serve that individual in the journey where they're at.